Welcome, everybody. Let's go ahead and
Welcome.
get this
Sorry
kicked
for the
off.
holdup. We are working on our security. It's excellent this week. Welcome to Designing on the Front Lines, episode 3. I'm your host, Morgan Hutchinson.
Hey, and I'm Matt Fields. I'm an emergency physician and also a faculty in the health design lab at Thomas Jefferson. And this is the third episode of Designing on the Front Lines, where we are bringing together designers and healthcare providers to make healthcare delivery better through better design.
Welcome. Hope you guys are enjoying a nice Friday. It is rainy here in Philadelphia, and we are joining you with happy hour drinks, his and hers drinks. I've got a Sauv Blanc. What do you have over there?
I have a little bit of bourbon, one of my all-time favorites, Basil Hayden. Yeah.
Awesome.
Tried and true.
So we've got an amazing group of guests with us today. We're going to jump in. Sorry, we're a couple minutes late. We would like to encourage everybody to turn your video on, join us in our happy hour, and use the chat box to introduce yourself. Tell us who you are, where you're from, and what you do, what you're interested in, anything really, as long as you're not Zoom bombing us.
Yeah, awesome. So we got some great guests here today. We have Sabrina Paseman from Fix the Mask. We have Erin Peavey from HKS Architecture, and we have Nick Dawson from the Emergency Design Collective. So I am super excited to hear from all of them about what they've done and the cool design stuff they're doing. But first, I think we're gonna do you mind if I do a quick share from this week, Morgan?
Absolutely. I'm helping Sabrina jump on, so you know what? I guess I'll allow the just as once.
Awesome. Okay, cool. So this past week, I was working a clinical shift in the emergency department, and I got inundated with COVID patients, actually. A local nursing home became a hotspot, and they started shipping all their patients over, and I was running around like crazy, and I needed to find one of our paper algorithms for working up the COVID patients and how to triage them appropriately. And I came across another example of poor design in healthcare, which was the lack of organization of any of our documents. It's, again, another example of how I feel like healthcare is always a black hole of design. And I feel like it could really be better. I mean, like, imagine if this was the cockpit of an airplane and this was how all of the emergency landing instructions were organized. Sorry, am I sharing my screen? I didn't share my screen.
I don't think so.
Oh, I didn't. Okay. Sorry, I want to try that again. My screen didn't share.
Now it is.
Now it is. Okay.
Although there's a lot of things. So
All
you
right.
may want to maximize that.
Oh, whoops. All right. That went better in the rehearsal.
Awesome.
All right. So this is what I came across, and this was how things were organized at my desk. It looks like a picture probably in a hospital from 20 years ago, but this was last week, and this is what it looked like. And again, imagine if it was like the cockpit of an airplane, and these how things were organized, and this was like emergency landing gear up here or something. Things really wouldn't fly, literally. And so, a design challenge out there. How can we make this better, and why haven't we?
Absolutely. That's a great design challenge. I suppose since you've mentioned one of the design challenges, I'll mention one of the design successes. Our students here at Thomas Jefferson University are super creative in our design lab, and they have been kicked off of the campus in order to keep them safe, keep our PPE supply stable. And so they have been helping us in every way they can to design ways to help us maintain our PPE supply. This is one of our students here who designed this 3D printed adapter to help us fix broken PAPRs. This is the bunny suit that we use when we're doing high-risk intubations and other procedures. And so super proud of this, guys.
Yeah, that was awesome because these PAPRs were not functional simply because of a poor connector. And, just be able to custom 3D print an adapter to fix these was awesome. Well, I have one more share. For those of the people who were on last week, I talked about this epic dessert that's coming out, the budina mixed with coffee. And I'm sad to say I still haven't been able to try it yet. It's you have to special order, and I haven't been able to obtain it, but I will hopefully get it this week, and I will tell everybody about how awesome it is.
Thank you, Matt. I appreciate that. I actually get daily updates from Matt on the Budina, so thanks for today's update. Our next thing, we're going to try out some cool things today on Designing on the Front Lines. We're going to do the poll function, so everybody get ready to vote. For all of you who are here on our prior episode for episode 2, we had a Zoom bomber. And today we're going to share with you the reaction to the Zoom bomber, and you're going to vote for your #1 reaction.
Here they are. So for those
I
of
have
you
to
who haven't
say,
ever Zoom bomb before, we were, and it was pretty entertaining, I got to say. So can we throw the poll up?
turns out the Zoom bombing actually ranked pretty high, but what ranked higher was Ellen Lupton's headphones.
I know those are amazingly
They are
coordinated with the
incredible.
back
I've been
wall.
looking for them all week. I'm gonna need some tips on that one.
All right, looks like we get some votes coming in.
Oh, one is a good one. That's a good.
I know one is pretty
call.
awesome.
Amazing.
So for those of you guys,
50%.
for those of you who haven't been there for our first two episodes, we did put them online, the recording on healthdesignlab.com/DOTFL. So you can watch those. We did edit out the Zoom bomb. I'm sorry, but if you really want to see it, let me know. Yeah, it was.
That's why you should join us live.
Got to be live to see that stuff. All right. Should we end the poll?
Should
Looks
we
like number
go
one's our one.
into? There we go. Awesome reaction.
Awesome.
All right.
All
So
right.
let's jump into our speakers. What do you think?
Let's jump into our speakers. Should we give a quick talk about what's coming up next week?
Yes, go for
Next
it.
week. All right. We'll just go ahead and plug next week while everybody's here. We already have 2 speakers lined up, and there's going to be another one. But the 2 speakers we have are 2 good friends of ours. On the left is Mike Natter. He is a medicine resident, and he's going into endocrinology, but he's also a cartoonist. And he is on Instagram, and he has I think 100,000 followers. He's at Mike Natter, and he draws really awesome cartoons and gives commentary on medicine and healthcare and design, and really just a really cool person to follow. So I'm really excited to hear from him.
And Trish Henwood is a rock star in design and medicine. She's an emergency doctor along with us. She has a history in being a leader in designing a response towards the Ebola pandemic in Africa, and she's been a leader also in the response to the COVID pandemic. She's going to talk about how hospitals respond to COVID and how we change our practice.
Cool. All right, well, let's go ahead and jump into our first guest, Morgan.
Let's see. Sabrina is having trouble getting on. Maybe we could start with Nick.
Okay, Nick, can you go?
I'm happy to, yeah.
Right.
I am impressed with all your visuals and your multimedia here. I'm also impressed with anybody who can draw a cartoon of themselves like what we just saw. That's incredible.
Yeah.
I'm seeing...
Oh, sorry. I just wanted to say real quick, Nick, I wanted to introduce you. So I didn't interrupt you. Nick is the co-organizer of the Emergency Design Collective, and he's got a background in starting and leading innovation programs inside health systems. And we have something in common. We actually met recently on one of these kind of informal virtual chats where it was just a few of us, and we discovered we had something in common. We both recently left the same institution. Can I say that?
Sure.
Yeah, Kaiser Permanente. We both left there, and now we moved on in our lives. So it was kind of an interesting thing in common. So Nick, sorry, go ahead, take it away.
Well, just to pick up that theme, I keep saying this in every one of these conversations that none of us would have wished these circumstances on the world, but I'm just so grateful that it brings us all together. And I'm seeing some familiar faces in this meeting and familiar names, and I'm glad to get to meet some new folks. And man, I'm glad we met along the way. I'm also seeing people with incredibly well-kept hair, and I would like to understand your secret of how you people are all keeping trim in this time. I'm afraid I'm never going to get to a barber again. So I don't have a multimedia production, but what I thought I would do is just share a little bit about what the group I'm working with is working on and the way we're kind of seeing and approaching the world right now. And would love to hear also if it sounds similar to work that everybody else is doing or thinking about. But I think from our point of view, and this will probably be pretty familiar to anyone who's been working in health and health design for a long time, but the pandemic has kind of shown the entire world how fractured and siloed our health system is. And I'm saying system in kind of the big all-encompassing sense, but it's also showing us that we don't even really have a system in a lot of ways. We were really good at treating somebody's broken arm, for instance, but we see somebody's social isolation as if it belonged to somebody else and it's some other institution's problem to solve, if at all. Somebody's job loss as not part of their health, right? Or somebody's access to food or transportation. Anyone who's worked in public health or worked in social determinants of health, I'm sure this all rings true to you. But what I'm finding is that now as a society, we're all starting to have that same understanding and same realization that almost every aspect of our life is fundamentally connected to our health and our well-being. And when we got together to start the Emergency Design Collective, and I'll tell you a little more about that, but admittedly, we weren't even quite sure what it was going to be when we started. One thing we really were focused on, though, was how do we create urgent, rapid responses to some of those things, both in traditional healthcare settings, but also some of those parts of life that are so connected to our health and well-being that don't always get the attention that internal innovation teams are able to give or apply to things that happen inside of a hospital or health system. And so we started this organization first by just calling many of you, I see some familiar faces who are working with us, and people that had started or led centers like the one you all have at Jefferson, or the ones that I've been a part of starting and leading. And it was a small handful of us. It was about 20 or 30 folks who showed up. And we said, well, let's at least orient around what some of these big challenges are. What should we all be working on? And that kind of grew to a group that, as of this morning, is over 500 people, kind of different levels of engagement and activity there. But a number of those 500 people are working across more than 20 really high fidelity, really amazing projects. And I'll touch on a few of them in a minute. But a lot of them are these things that are those kind of social needs of health, or non-clinical or upstream of sick care needs of health. And it's just been really incredible to see that come together. It's also made me think that it's a little bit of, I hope I can use this and say it humbly, but there's a little bit of like a field of dreams thing there, where I've talked to so many of our members who've all said some version of, I have wanted to work in this space for so long. I've wanted to do something like this for so long, or I've been making products my whole life for big companies. I want to do design work that has social impact, that improves people's lives. This feels like a space to do it. So if nothing else, having been part of holding that space in inviting people in and creating a big tent has been just absolutely incredible. So it's led us to this place of asking the question of, we have this concept in the world of a B Corp, a benefit corporation. What does it look like for the new normal to have an H Corp? And maybe we're kind of prototyping the first H Corp, but I love the idea that might be a new societal norm, where any business or organization says, in addition to our core driver, we also feel responsible for the health and well-being of our employees and our customers or the communities we serve. What does it mean to be a restaurant that values the health of its workers every bit as much as the quality of the food it serves or the customers that come through the door? What does it mean to be a corporation that says the same thing, that our responsibility is to the health and well-being of our employees and the communities that we inhabit or share? So the types of stuff that the EDC has been working on kind of runs the gamut. It's kind of three big buckets of things. One is designing for frontline healthcare and healthcare workers. Some of that work, like probably a lot of you all has been focused around PPE and creating a playbook of clinically vetted PPE face shields and gowns that makers can produce. And we've had some pretty dramatic results with that, of being able to get more than 2,500 face shields into frontline clinical use, and getting gowns into frontline clinical use. But some of it has also been around mental health and the inevitable PTSD and the struggles of working in an extremely stressed system and environment. So there's some work unfolding there, led by Tracy DeLuca, that's absolutely incredible. There's another domain which is designed for vulnerable populations, and that kind of runs the gamut of anything that would be defined as a vulnerable population. Devika Patel and Mariko Kelly are doing work around the unhomed population, and it's kind of taken two different slants, but one is about how do we connect, kind of build a marketplace of being able to donate abundance of resources, and then how do we have a marketplace of being able to get them to people that have needs. And then there's the work that's focused on how do we treat homeless people with COVID, and how do we do it humanely. And you may have seen some of the images that are coming out of these parking lots that are opening up. It's great to give people a space, but that's not exactly a human experience. So how do we think about a more human experience there? There's groups working at different ends of the age spectrum. So Kate Piper is leading an incredible project around social isolation in seniors, and also really quickly learned that people who are working in elder care spaces don't feel celebrated the way we're celebrating frontline healthcare. In fact, they feel stigmatized because of the high case rates in nursing homes. And there's another group working on teens and these amazing life milestones that they're having to experience in different ways, and the struggles that teens have with isolation while trying to be socially distant. Um, and the other last domain is what we're calling design for the new normal. So like many of you all, we're all kind of thinking about, if this is the great pause, the great time when society has all pushed pause in a heartbreaking way, how do we come out of it designing a new normal that we want? Not one that's just functional and responding to the urgent needs, but how do we build something that is that's the systems that are oriented around health and well-being, that are oriented toward seeing people as holistic humans, not just a need to be fixed or a nurse to round on patients. Some of that is heartbreaking. One team led by Natasha Blum is working on death and dying and grieving and end of life care wishes in the age of the pandemic, when some hospitals aren't even allowing visitors in. Another group is working on kind of another end of that spectrum, which is, how do you stay fit? How do you stay healthy? What about kids who might be going to college on an athletic scholarship? What happens if there's no more sports to play for a year or two? What if that's your primary identity? So how do we start to design for a new normal? How do we design a new way of virtual distance learning that's not just taking the antiquated classroom model and sticking it on Zoom? So there's a lot of projects happening in that space. And with that, why don't I take a deep breath and pause, and Matt, you can react to some of this or focus me, or maybe there's other folks that have similar experiences or working on similar things.
You got me. Yeah, Nick. Oh, wow. That is great. I love design for the new normal. That's totally right on. I love hearing about the project. I have so many questions about what you guys are doing. I got to say, when all this was going on, I remember having a conversation at one point. I was like, wow, I really love a place that I could go to where I could just see somebody bringing together a lot of these projects. And I thought, should I do that? And I'm just so relieved that somebody else did that and that you did that, because I had somebody better than me. And so thank you for that. And I have so many questions. I guess I guess my first question I'd love to know is a little bit of how the sausage is made with some of these efforts, right? So tell us how it came about.
Yeah, it's interesting. I'll tell you by way of a parallel anecdote. My other half, my fiance, comes from the Obama administration. Her and several of her former colleagues got together and stood up the organization they're calling the U.S. Digital Response. So imagine kind of the government techie mirror to this health designy thing we're doing. And we were both getting started at the same time. And Amanda and I kind of said, well, damn the torpedoes. We're going to run at this 100 miles an hour. We don't know what it's going to be. We'll make it up as we go. And the USDR spent a week really getting clear about their processes and their kind of methods and their kind of organizational structure. And in hindsight, I'm lamenting that we maybe could have done the same thing and had a little bit more intentionality. But we really are doing it organically and on the fly. So we had somebody step forward, this incredible med student named Jess Hawkins, who said, I can help run operations. We said, we didn't think about operations. We do need that. And Jess then said, I'm going to pull a team together. And so now there's 4 or 5 or 6 people that are made this ad hoc operations team, and we're starting to have conversations around what does onboarding look like. And so some of our IDEO alums said, well, we had this amazing onboarding process at IDEO. Let's borrow from that and some other best practices. And now we've got a leadership training and a process for people who maybe not have as much proficiency in design to be able to kind of ladder up through working on projects, going through some training, going through some onboarding. So Matt, it's a long-winded answer to saying, we despite calling ourselves designers, we didn't actually design the organization and our processes, but we're doing it as we go. And it's connected to what I think is probably the core tenet. The core value has been work in the open, do everything open. So we're calling it an open source design collaborative, but it's also the idea of like, if we're building it, we're going to build it together. You're going to see how the sausage is made. If you're into this kind of thing, you better be able to embrace ambiguity or making order from chaos, because we don't have the answers. We've never done it before. So a lot of that, how we're doing it is kind of being built on the fly.
Yeah, and I mean, super impactful. I just saw the article that came out in New England Journal of Medicine Catalyst, where you were looking at approaching the question of, why are people afraid to go back to the emergency department? How might we make people feel better about going back to healthcare to take care of their needs. That's a huge issue we're seeing. Patients are not coming to the emergency departments yet. We know they're still having heart attacks. We know they're still having strokes. That those numbers don't change just because the pandemic's here. So that really cool. I mean, I'd love if you want to. I'd love if you comment on that project, or if there's another project out there that just like kind of jumps to the top of your mind as like one of these kind of poster child products of the EDC effort.
When people say, "Oh, I can't tell you which one of my kids is my favorite," I love them all equally.
Yeah,
I have that same appreciation for these projects. It's also a really tremendous celebration of the people who are doing the work. It's something that's very different for me in this moment in time. When I've been inside health systems, I've kind of split the role between the executive part of the job and also keeping up my craft and practice. And in this moment in time, I'm really stepping back and saying, what space do I need to create? What support do I need to give so that these project leaders can take over and run these things? So I touched on a few of them. I touched on a few of those names. Laura is the doctor who led the emergency room design project, which is absolutely incredible. There's a couple that are, because they started earlier, they're just a little more mature in their process because they've had a little bit longer runway. One is around blood donation that's being led by Abby Don and Katie McCurdy, who I think many of us know is on that project. I think some other folks are on that project as well. And they started looking at like, how do we make blood donation safer? And then very quickly realized, well, they've already solved for that. That turns out it was already pretty safe to do. But the real problem is in the messaging. How do we get the demand out there? How do we grow demand? And you all may know that blood supplies are in really, really critical shortage right now. So their work has really been around creating demand and partnering with other organizations who run blood donations to help them with messaging, to help them with protocol, some of those things to make it kind of increase the messaging around how safe it is, how accessible it is. And they've just built this amazing prototype that's like this really simple web tool of like, am I eligible? And if so, get that make the call to action, like really simple, one click. Now all of a sudden you're registered. Now you have an appointment. Now you're donating blood. So that's one that comes to mind. I said I wasn't going to pick one, so don't tell anyone I singled one out. They're all incredible projects.
Awesome. Yeah. And I don't know how we're in time. There's one quick question here I want to get some audience questions in as well. So I'll give this one question and then we'll go on. I love the idea. This is from Hamid Ghanadin. I hope I'm saying that right. I love the idea of an H Corp. Also wondering if B Corp already covers the health and well-being of its community. Also, one aspect of human well-being, for example, is the environment. And what do you think about that question?
Yeah, it's great. I think for us, H Corp has been just almost this notional concept. I don't know that we're not going to come up with like the better lab or the B lab and try to really create a new corporate structure. But I think it probably is implied in B Corps. If the ones that I know that come to mind for me, Patagonia, for instance, they do take the environment and the health and well-being of their employees every bit as much of a priority as profits and revenue. So I like the idea that maybe that's already baked in. And maybe that is the thing that comes out of this, is that more organizations formally adopt a B Corp status. But if nothing else, I would just love it if our entire societal orientation toward health and well-being shifted to understanding that every part of our life is fundamentally part of our health. There's that graphic that I bet many of you know that's kind of the iceberg that says, like, look, 20% of your health and well-being is medical care and is medicine and genetics. 80% is where we live, what we eat, what resources we have access to, what support systems do we have, what's our social life like, how connected are we? Like, just coming out of this with a societal understanding of that and starting to think about how do we treat people as the whole iceberg, not just the little tip above the water. What systems do we have to do that? That's, to me, what the principle of an H Corp is.
Awesome. So true. Well, thank you, Nick. I think we're going to go ahead and transition to our next speaker. Morgan, do you want to?
Yeah, thank you, Nick, so much. It's really great to hear from you. We've all been a fan remotely here. So also calling in from San Francisco, we have our group from Fix the Mask. Sabrina Paseman has unfortunately learned today that I have some severe technical difficulties as we had a trouble getting her onto the call. But thank you, Sabrina, for hanging in there. She is here now. She is a Cornell-trained mechanical engineer and co-founder of the company Fix the Mask. previously was a product designer at Google. And when the pandemic hit, came up with a very cool, very low budget solution that can be used anywhere in the world to basically fix the mask, creating N95 level masks out of surgical masks. One thing that we always talk about with our students is how can you solve a problem using no money at all, and how can you solve a problem using all the money in the world. And this is a really cool, very affordable solution to people across the world. So Sabrina, I will hand it over to you.
Yeah, exactly. Thank you so much. Really inspired by the group here. So let me share my screen. Can you guys all see? Yes, nod, perfect. All right, great. So as Morgan kindly introduced, my name is Sabrina, product design engineer, actually trained at Apple, and really excited to share this solution with you guys. So what is Fix the Mask? We are an organization that is working to supply safe masks to those in need quickly. And what that means is that, you know, this virus does not discriminate between income level, does not discriminate between occupation. In order to actually stop the pandemic on a global scale, we need to be able to protect everyone as much as we can. And in order to do that, the solution needs to be cheap and it needs to be effective. So how do we actually solve this? So as we all know, the standard for protection here is the N95 mask. As you're well aware, there's a huge supply and demand problem. And these are statistics that were done in the study in 2015 of like a hypothetical pandemic. So these numbers are sort of approximations, but it remains that there clearly is a huge supply and demand problem. So when attacking this, I try to understand what makes an N95 mask good and what else out there exists that potentially could get us to a similar level. And so when I took a look, what's interesting is that N95 masks and surgical masks actually have really similar stack-ups. N95 masks have an additional layer for shaping, but inherently they have the same filtration layers. And so when actually looking into something that would be similarly effective to an N95, I knew I wanted to go with something that actually had melt-blown fabric that was charged inside of it. We can go into more details into that later. But another thing that's really interesting is that this is also an outdated statistic. This is from March, but every day in China, they were making 600,000 masks, N95 masks per day, but 200 million surgical masks per day. And after looking at the manufacturing processes for these masks, it's actually really striking how fast surgical masks are to produce. They literally, same input layers as you sort of saw from the beginning, they just cut them into squares and heat press them, whereas N95 masks obviously have a lot more processing that is involved. Now from a cost standpoint, it's also really interesting. N95 masks, base cost, I think, cost on the order of like $2 in materials costs, but as you're well aware, they're now on the order of $7 US, whereas surgical masks have remained cheap. And the really interesting thing here is that not all countries can afford to drop billions of dollars to buy N95s to protect their communities. We need to be able to use what they have. And if they have good quality surgical masks, they need to be used more effectively. Now, what is the problem with surgical masks? Well, an N95 mask is good because of two things. It filters well, meaning it can actually block through the bulk of the material. And also it fits well, meaning that it can't leak through the sides. And so our goal here at Fix the Mask was to basically, we know that filtration materials, these are the next best thing, right? And from a fit standpoint, we figured that we could solve that with a relatively cheap device. So where are we in testing? So we wanted to make sure that the solution wasn't just, you know, like a gimmick of like, oh, like fit in general should be better. And so we actually wanted to test it, right? So we actually focused on fit testing. We're doing filtration later, we're tabling that for now, but we really wanted to just prove out the concept. Like if this concept works, then we would actually move forward to validating the full solution. And so from a fit standpoint, there are two methods to test fit. There is the qualitative saccharin test, which is shown on the left in the fit image, which is basically putting a bag over your head, spraying stuff inside. We actually went with the one on the right, which is a quantitative method. And that quantitative method outputs a fit factor that I'll go more in depth into now. So that's what we ended up collecting our initial data set with. And so I'll take you now through what data we have. So we had these two options. Let's go into our data for version 1. So as you can see, version 1 literally was rubber bands. And what's interesting about this is that we came up with version 2 first in our engineering brainstorm, but I had no rubber sheet in my house during shelter in place. And so I was looking for something to prototype this with, and I actually just found rubber bands. But what was so interesting is that it was so effective that even though it looks so janky, we knew that it had to be something that we just shared because it's so easy to put together. So how does this actually work? This is data from the University of Iowa Carver School of Medicine. They actually just got published today in medX archive. So you can take a look through that later on. This is a lot of content, but let me take you through it. So what they did was they took rubber bands of the same size on 12 different faces. And they attached these rubber bands through 2 different methods. They attached it with a paper clip behind their head, and then they attached it with paper, to sides of a face shield, as you see in the bottom image. The data is really cool. Oops. So here we have the paperclip overall fit factor. So we're going into the second column now. What we have is that 11 subjects passed with the paperclip method. And the subject that did not pass actually is interesting because her face is so small that she's actually never been able to pass with an N95 mask before. So she's used to not passing this test. But when actually attaching the center seal up and back towards the sides of the face, even she was able to pass with a passing fit factor. And so this was extremely promising. Going into the third column here, breakdown by subject. So the way that this fit factor test works is it's actually an average of 7 different tests. One of those tests includes talking. So as you can see, all of the talking data for this is still not great, but that's actually common. Even N95 masks have an issue passing the talking test. So what determines whether or not something is passing is whether or not you have like an average fit factor that is passing, and that is what we achieved with just rubber bands. So this was really encouraging and is something that we immediately shared because the data was so good from the beginning. But the problem here is that this solution is not the most comfortable. So my team wore this solution for 6 hours. After around hour 4, I noticed it started getting uncomfortable on my nose cartilage area. And after hour 6, when I removed the mask, I definitely had a big indent. And so it's not something that like can necessarily be worn comfortably day in and day out. So we knew that we had to iterate on this design. So, oh, I did have this. Cool. Sorry, my internet's a little bit slow, I guess. So we came up with version 2. Now, version 2, as I mentioned, is something that we had from the beginning. The band was wide, so we were hoping that the width of the band would help improve the comfort. Now let's look at our data for version 2. Oh, by the way, there's a lot of iteration work done. I can go into detail here, but we can talk about it later too. So moving forward. Well, moving forward, we have data for version 2. Is my screen advancing for you guys? Oh, here you go. Okay, version 2. So version 2, we have a much smaller sample size of data. It was done internally, and you can see that version 2, whoa there. Version 2 worked well for only one of the 4 participants. So, but version 2 with cushions added actually got all participants above the N95 fit factor level. We tried the same test with also a KN95 and found the same thing. So we now have fabrications of version 3.1. And now this is actually incorporated not only the cushions, but also a bunch of other factors for improved comfort. We have prototypes of these, and what we're looking for right now is actually to get a larger sample size of our version 3.1 design. So taking you guys through it, I hope my computer doesn't crap out on me again, but basically we added nose cushions, secondary head straps so it doesn't slip off the top of the head, and added neckties. And actually what's interesting is that having a dual joint as opposed to a single joint like our original design is actually a lot more comfortable. So with these prototypes, our next steps are basically all we need is more data. We just need people to help us collect lots of different data on lots of different faces. So what my call to action to this group is if you guys have access to any of these 3 things, please reach out to me. So if you have access to filtration, a TSI 8310A system or equivalent, would love to get more data on filtration. From a fit standpoint, we have the, if you have access to a Port Account Pro, like I will send you braces, and if you would like, you or your hospital would like to pilot a study at your hospital, please reach out to me. If you don't have access to a Port Account Pro and just want to give us comfort feedback, we are actually crafting a 15 to 30-day study where we ask participants to wear this device multiple days in a row and basically let us know if it was uncomfortable, what was uncomfortable, if you didn't wear it today, why didn't you wear it today, etc. And we're actively looking for that feedback too. So that is where we are in our status. Any questions following up?
Thank you so much, Sabrina, for coming on the show. I've been trying to get you guys on the show since before we even started, and I'm so excited that we got you here today. This is like an incredible solution, so elegant, so easy to implement, and so cost effective, especially since there's such a lack of N95s. And let me tell you, you guys wore that for 6 hours and you had marks on your face and you felt like it was uncomfortable. Like, we wear N95s for all of our shifts every single day, and they're incredibly, incredibly uncomfortable.
Yeah.
Is there anything that, I just wonder, like, from a design perspective, is there anything in your history as an engineer that you thought, like, that sort of inspired this? I know that you said you were sort of trying to find some way to prototype and that just kind of ended up being so successful, but
Yeah.
can you compare it to anything else that you've ever done?
I think what makes design in general powerful is understanding the core of the problem and then iterating on the fragments of the breakdown. So basically taking an N95 mask at the time, at the end of March, a lot of people were making things that looked like N95 masks. They would make the 3D printed body and they would basically just swap out the filter material. But actually, the thing that was interesting here was that it wasn't the shape of it that made it effective. It's actually the filtration material. And understanding, basically breaking down the innovation into core blocks and basically saying, okay, the filter material is good and it exists. Like, how can we actually improve the thing that actually matters, which is fit? So I think that what makes a good design, and what I sort of pulled upon in my design history to basically make better designs moving forward, is to really understand the problem fully before trying to iterate on a design. Yeah.
Amazing. Thank you so much. I really appreciate that. So I know that you guys are trying to reach certain people, and there's a lot of people on this call who are trying to, reach out and contact each other. So what we want to do next is actually bring everybody into breakout rooms. So people can talk in smaller groups, sort of introduce themselves in a more friendly, sort of small way. We're going to do a 5-minute breakout room. And
yeah, I actually want to, like, before we, I mean, it's just so cool how many people we have and from all over. I see Grace from Sarasota, Florida. What's up, Grace? I see Kristen Apple. Hey, you were on last week from Boulder. Hey, Kristen. We also I saw Toronto. Oh, Colleen from University of Michigan. Hey, Colleen. Oh, and I can't forget to mention Ellen Lupton from she's a curator at Cooper Hewitt and Smithsonian Design Museum in New York, and she was one of our guests last week. So thanks for coming back. And I think I also saw some guests from outside the country. I saw Toronto, and
last week we had Mexico. We've had some participants from Africa and Ireland. It's been great.
Heyman. Yeah. Hey, what's up? And then I also saw Maverick, 2 from Toronto. Awesome. Thank you guys for coming. And I also saw Dublin, Michelle Flood. Thank you guys for joining from all over. This is really, really awesome to be able to get together despite the issues with everybody being able to get together in the pandemic. So this is really cool. All right. So yeah, should we go into breakout rooms and get to know each other?
Absolutely. Let's do it.
All right. Everybody should introduce themselves, share what drink they're having on a Friday afternoon, and
even if it's
tell us
water.
what you're doing.
Oh, so great.
Wow, that went by way too quick. We just got
know.
cut off in the middle of a question. So
Oh
That was
boy, but we've
smooth,
only
though.
got 10 minutes. Yeah. Sorry, Erin. So we do not want to delay any further. We have a super amazing last speaker today, Erin Peavey. She is an architect who has focused on health and wellness throughout her career. She has won multiple different awards for her awesomeness. She works with HKS and she's been named Best Under 40 by the Academy of Architecture for Health, and has just been so great to come on the show today. So Erin, thank you so much for joining us. I'd like to turn it over to you.
Awesome. Thank you guys for having me. I'm super excited to be here. And I come from a family of physicians and care professionals of different sorts. So I feel humbled to be here with you guys. Yeah, I'm an architect and design researcher. Have a background in psychology as well. And I think really I spent a lot of time in healthcare, which is how I know Bon originally. But I've spent the last few years really focused on social isolation and loneliness and the role of the built environment. And I originally was not going to do slides, but I think I am now, because we have a little slide deck from a presentation we did a few days ago. I just want to talk real quick about sort of loneliness and social isolation and how they're actually a little bit different. I think all of us are now fairly familiar with some social isolation, and that's objectively being alone. But loneliness is this subjective feeling of being alone, which we can feel whether we're in a crowded room or all by ourselves. And let's see if I can get the slide. There we go. And we understand that these have some serious health impacts, increasing our risk for early death, for social isolation, and for loneliness, and even just for living alone. So I've been thinking a lot about that as a way of how do we reach out to people right now, and how do we design our environments differently to support people that are either living alone or co-living. And we know that being socially connected reduces the risk of death by 50%. I mean, that's amazing. And there's no doubt that it's a national health epidemic. I mean, I think we've been talking a lot about the economic recession and all of the concerns around that, but there's also a social recession. And I think that the health impacts long-term of something that's very necessary of protecting ourselves right now are going to ripple for a very long time. And I think really what I love the idea, I've been taking a bunch of notes, but when Nick talked about design for the new normal, I actually am starting a podcast series that is about envisioning what that could be, what our environments could be, and what we're learning from this period that we want to be able to see for the future. So when this had all started, it's basically like this got, South by Southwest was canceled, and we were going to be presenting around this framework to talk about what is important when we design for social health and social connection. So we talked about how important it is to have these spaces be accessible, to have them activated and full of different types of things that meet different types of people's needs. So also to have choice in, do you want to be sort of by yourself and alone and sort of watch the people, or do you want to collect in a big group space? We're all sort of along that continuum at different times. And I think all of these have kind of become blurry to us because everything is changing so quickly, and a lot of the things that we just saw, we can't do right now. And so I think that still, as we think about both what our physical environment should look like and how we want our virtual environments to look as well, there's a lot to take away. There's a lot that we can still do understanding this framework. And I think that's really kind of part of what I wanted to share, is to talk about, Nick, I was so excited to hear you talk about social determinants of health. And I think, once we start to look into the literature, we understand that the way that our built environment is created impacts all sorts of things, from our social connection to how physically fit we are, and whether or not we get asthma. I mean, there's and I think as we have become more and more autocentric, we've sort of taken away from the human realm. So we've become more dispersed, and we spend longer times driving, and we spend more time sort of pulling into our garage and going inside versus like hanging out outside and meeting our neighbors. So Morgan had mentioned, like I've talked a lot, I'm on a crusade to promote front porches because they're just the best sort of, we kind of talk about threshold spaces, that in-between space where you can connect with your neighbors, you can connect with other people, but still be sort of safe. And I think that's how we used to design. We used to design for human needs, and we always should. And I think that, you know, as we plan for what is it that we want, I think that we need to hold our architects and our legislators and our, you know, code officials to a norm that doesn't just look at, you know, what is short-term economically profitable or, you know, benefits a small section, but sort of understand the ecosystem around the spaces that we're creating. So Julianne Holt-Lundstedt, who is a researcher that has spent her whole career sort of focused on this area. We've been talking about some specific areas like Macau, or like there's I can't remember the name right now, but it's a place in Italy that they're sort of isolated, but they all are very socially connected, but they're able to sort of keep themselves safe because they have, you know, that sort of border, and they're completely interdependent and form sort of an ecosystem that is self-contained. And so I've kind of been using that as an analogy of, well, what if we were able to create spaces that look like that, neighborhoods that look like that, where we had our groceries and we had our schools and the people that supported us that lived next to us. I think there's no doubt that we were, you know, we evolved and we're born as people that were meant to connect with one another. And in no way is that only about the built environment, but I think a lot of times we, like, the built environment is just in the background. We're like, no, that stuff, it doesn't really impact our behaviors. And it does in these little ways of what we call affordances. It's sort of like, you know, how easy, Matt, I loved the design challenge that you set up, you know, like how much better would it be if it didn't look like that when you went into work. And so I think, yeah, so I know that we're close on time, so I wanted to keep it short, but thank you guys for inviting me.
Thank you so much, Erin. It's like incredible to have you here. I could listen to you talk for an hour about all of this. I feel like all of us could, right?
You're so sweet. Thanks.
So we, like, I think that, you know, what you're kind of, to me, one of the things that I've been thinking about is so many people are like, why are we calling it social distancing, right? Like, why don't we call it physical distancing and think about how we can stay socially close in a time where we have to be physically distant?
Yeah.
You know what I mean?
And
so I think that's so cool to
yeah.
hear you talk about, you know, how you imagine space in that kind of, in that way.
Well, and I don't know about you guys, but I mean, I think one of the things that is clear is that, like, we're meant to, you know our neighbors, and we're meant to connect with more people on a repeated sort of casual basis. And so the report that I put out looks at the ways in which design impacts social capital, and so both strong and weak ties. So sometimes it's like, I feel like we're moving to this digital realm where people drop off our groceries and we don't need to, like, see as many people. But the thing is like, that interaction with the barista or with the grocery person, there's actually research that's showing that that can be really important for people's mental health, and even people coming out of addiction and trying to stay out of addiction, is that those casual interactions repeatedly, you know, it's sort of like that sustaining, especially the more we live alone. So yeah, thanks.
Absolutely cool. Matt, I know that we were flipping coins on who got to ask you what questions, and Matt actually won that coin toss. So
I had so many questions for you that actually, I mean, I love you were talking about.
We did some editing, so don't worry. It'll only be, you know,
and
couple hours here.
I know, and I was just listening to a podcast about, like, Kirkbride, like, facilities and all this stuff, and like, but and of course I've been actually taking a like deep dive into a lot of looking at how we leverage our existing built environments to combat a lot of these patient-centered outcomes and actually provider-centered outcomes, and especially in the emergency department. And I was having this great conversation too with another architect too, who was talking about how things are different in the United States as to other areas in terms of things we do in our healthcare systems, in our hospital, specifically with just small things like, windows, big thing,
Yes,
right? Like
yes.
why don't we open our windows in the United States, but in
Yes.
other countries they do, and they ventilate. And does that impact, health? Does that
Yes.
impact viral transmission? Does that impact COVID? And
And does it impact your ability to, for instance, combat COVID when a hurricane comes through and when you have no power? And, I lived through Sandy, and in NYU and a number of others sort of shutting down and not having power. And it's like, well, gosh darn it, it would have been great if you could have opened your window. And been able to, both experience that for a lot of reasons. So yeah, I love that. Thanks.
Yeah. And so I guess, I don't know, I want to keep this conversation going, but we are at time. And so it's Friday afternoon. So please,
Unfortunately,
everybody,
we work on time, keeping it exactly that 6 o'clock time.
yeah. So please, everyone, keep in touch with us, and we will definitely, we want to hear what you guys want to hear about and conversations you want to have. And if we need to continue one of these conversations, and I think we need to continue all of them, but we can do that. We have a couple of great speakers lined up for next week, and we're planning to add a third one as well. And yeah, so I think we're gonna go ahead and call it. It's at 6 o'clock. I'm gonna try and cue up a little outro music, and everybody.
Thank you guys so much for joining us this week. And last week we've gotten so much support from all of you, and please reach out to us. I'm going to send out the link to the poll and email it out to you guys later, but we have really enjoyed connecting with so many people in the last couple weeks, and we look forward to seeing you next week.
Thank you.
All right. Thank you, everybody.